Oh, okay. All right. Oh, wow. Okay. Good morning. Thank you guys for being here. So I am Sasha Zagaloff. For those of you who don't know me, I'm a psychologist in the Department of Psychiatry and Behavioral Sciences, and I'm very excited this morning to be introducing Dr. Barbara Brandt to all of us. So she is the director of the National Center, which is based here at the University of Minnesota and is a public-private partnership. And so she'll be telling us a lot about what the National Center is doing. And one of the things the way that I've come to know Dr. Brandt's work is through FIPSI, which is a course dedicated to teaching interprofessional practice across the academic health center. So she is a tenured professor in the School of Pharmacy and has been a principal investigator on over $25 million in grants and contracts. Her CV is quite extensive, and so she asked me to just give you some brief snippets. But so she has been a speaker for the Institute of Medicine, now the National Academy of Medicine, the Global Forum on Innovation in Health Professions Education, the Josiah Macy Foundation, Robert Wood Johnson, and she got her bachelor's from the University of Illinois at Chicago, and then completed, she got her PhD degree there as well, from Urbana-Champaign, excuse me. And so her honors include Woman of Achievement from the University of Kentucky Chandler Medical Center, the American Association of Colleges of Pharmacy Innovations in Teaching Award, the University of Illinois Distinguished Alumna. She is an honorary alumna of the National Health Service Corps, an honorary fellow of the National Academy of Practice, and then in 2018, just recently, the University of South Carolina Greenville a Luminary in Medicine Award. So she will be speaking with us this morning on interprofessional practice and education, and specifically how it aligns with our department based on some conversations she and I have had previously. So join me in welcoming Dr. Brandt.
Thank you very much for inviting the National Center here today to share with you our work. And I have to say my team, or our team, is back in the back of the auditorium. They don't usually get to see me speak because much of my discussions, this type of presentation, I do elsewhere. So thanks for the opportunity. So today, we actually arranged this maybe about 9 months ago. It was quite a while ago. And so Sasha, Dr. Zagaloff, and I spoke on January the 30th. And I said, what do you want me to speak about? You know, I can talk about the National Center, but what is it that's going to be helpful for the Department of Psychiatry? So she gave me a 20-minute sort of like a what's going on in the department. And what resonated with me was that this department had a retreat in January, so it was really fresh. So I'm going to use this as the presenting situation and to weave in the work of the National Center. And rather than one of my colleagues pointed out, yes, this is an alignment with the National Center, but frankly, it's an alignment with the national imperative for team-based care and interprofessional practice and education. So the learning objectives today is I'm going to describe the work of the National Center to implement policy, education practice partnerships, and an informatics approach to what we call IPE science. I'm going to articulate how the department is truly laying the foundation for what is known about critical success factors in this work. And then as I've had the discussion is you sort of put out some ideas for the department for opportunities and new ways to think about integrating the clinical education and research missions to achieve health and learning outcomes for stakeholders. So a little bit about the National Center. This was awarded to the University of Minnesota back in 2012. It was a national competition. Health Resources and Services Administration held a peer review, and there were 4 private funders who put money in before the University of Minnesota was even awarded. So about $14 million. It's their vision that the University of Minnesota is carrying out. So in that peer review, we were up against places like UCSF, University of Washington, Virginia Commonwealth, Colorado, and the like. So as I tell people, it really is an honor that we've carried out the bold mission to be the National Coordinating Center for Interprofessional Education and Collaborative Practice. So you might notice that we use the term interprofessional practice and education, and the acronym IPE traditionally is interprofessional education, but we talk about the new IPE, that education and learning and healthcare and practice are inextricably linked. So we use the World Health Organization's definitions on what is interprofessional education and collaborative practice. And the one that's really critical is what is education, interprofessional education, and occurs when two or more professions learn with, about, and from each other to enable effective collaboration and improving health outcomes. I won't read the definition for interprofessional practice, except that the National Center truly believes, and this is why we are awarded the center, that unless students and residents and fellows are embedded in practice in seeing team-based care, health systems are going to continuously be retraining the workforce. So that'll be a theme you'll hear me talk about. So when we wrote the proposal, we gave a very bold idea, and it was based on experiences here at the University of Minnesota. And it was sort of like go big or go home. And so we used the term of the nexus. And we intentionally use this weird term because we want people to say, what is that? And over time, we've learned how to talk about it, and we're actually doing it. And so we believe that we need to redesign both healthcare and healthcare education and delivery simultaneously to be better integrated and more interprofessional while demonstrating outcomes. And frankly, that's our 20-minute conversation about the department. I am seeing indicators that that is happening already. So we talk about, from the very beginning, moving beyond academic tourism. And when we say academic tourism, it's the model in health professions education of, oh, you got to do a month here and you got to do 2 weeks there, you got to see this. And we're flipping it to aligning interprofessional education with clinical practice redesign. And what we mean by this, and what I was very interested in, is that students and residents are dedicated to a clinical practice. That it is really how do we design around this learning system, learning organization, to have an impact on clinical redesign, but also on patient outcomes. So we have talked about this concept from the very beginning. So this is how I understand the presenting situation. So just like a physician and psychologist and like do diagnoses, we educators do diagnosis of educational situation. So as I understand it, you have a department head who is charged and supportive of teaching practice redesign to be more interprofessional and team-based. When I was taking notes furiously, as Dr. Zagaloff was telling me what was going on, she said, we've come a long way in collaboration. And then she described the students that spend quite a bit of time in the department and learning together. And said it's so successful that we have 7 social work students and we think it's going to be up to 10 next year. She described joy and taking pride in teaching, that people come to this department because they love teaching. They love the academic mission. But she also described challenges to teamwork. And one of the biggest one was just logistics, different systems, basic communication difficulties such as email. And I told her, I go all over the United States. We've done hundreds of presentations, and I can tell you that this system interface is one of the most challenging in the entire United States. She did tell me about staff turnover, and we feel like we're constantly re-educating. And then she described a retreat. And I asked her over the weekend, send me the document that set the tone and set the stage for the retreat and the 7 work groups. I got that on Monday. I'm real excited about the 1 o'clock meeting. So she talked about one group is working on access. How can the department assure that patients will have access to level of services? So when I read the document on Monday, it was really clear that there are a lot of people that this department needs to manage, a lot of intake of patients. 2 groups are working on culture. One is working on creating a teamwork culture, and another is focused on joy in practice. And she used the term that was, and I'm going to be interested in exploring that, a teaching clinic that needs to shift to be financially sustainable, needs to break even, full complement of professionals for financial sustainability, and what is the incentives? What is the incentives to do this work? Another group is looking at interprofessional education and teaching interprofessional collaboration through, and to use the term, combined didactics. And there is something called the Interprofessional Education Collaborative Competencies, which are going to either be currently or intended to be woven into this work. With many practices, documentation and finances is very real. And we live in a fee-for-service world, primarily. So the physicians often are the only profession that is paid. There is a desire to integrate research, education, and clinical practice, and we want to be an innovator. We want to be an innovator and a leader of new ways of practice, is what I heard. So what I did is I took this in and I wrote a little lengthy letter to you, and I said, this is what I'm hearing, and this is what I think I can talk about if you're willing for me to take a risk, for me to talk about what I'm seeing in the department and what the National Center is working on. So again, this is how the department is aligning with the national imperative for interprofessional practice and education, and I am presenting ideas and tools for you to use and consider. So the first national imperative literally happened on January the 28th of this year. The National Center, in March 2017, I got a call from the Accreditation Council on Graduate Medical Education to come down to Chicago and spend a day with them. So I spent the day with the vice presidents who are in charge of the CLEAR visits, clinical learning environment reviews, for all residencies in the United States. And behind closed doors, they said to me, we do 600 to 800 CLEAR visits a year. So they're probably the only organization that has their finger on the pulse in health systems about learning. And what they shared with me, because they do a 360 review, they talk to the chief nursing officer, the patient safety people, that the environments in which medical residents, their concern, are learning in is a concern to us nationally. We think that this needs to be interprofessional. Can you help us think that through? So they have formed the National Collaborative on Clinical Learning, Improving Clinical Learning Environments, NCYCLE, made up of 32 and growing interprofessional or individual professional associations. And in October 2017, they hosted a symposium. We helped them design that, and which was very dynamic. And just on January 28th, they released the report from that, Achieving the Optimal Interprofessional Clinical Learning Environment. And NCYCLE will co-host the National Center Summit here in Minneapolis in August 18th through the 20th. So we're working with them now, and they will also be hosting their second symposium, 2 days, invitational, before our summit. But what's really this time around, and when you read the report, they are very, very serious about educating leadership of health systems. So they're going to be inviting health system leaders to that symposium. So again, this is all very recent developments. In that report, and I have prepared a notebook for the department with all of the reports and the like that I'll be talking about. It talks about what is a clinical learning environment and why. It talks about healthcare in the United States. It's growing more complex. It requires for providers from all professions to be adept in collaborating to learn, assess, and problem solve, and deliver coordinated care in new ways. It talks about technology impact, specialization, access to health information, but importantly, for the foundation that this department is putting into place, new delivery structures require that various health professions think differently and purposefully about the simultaneous optimization of learning and patient care. So what you're seeing nationally in the national imperative is this concept of becoming a real learning organization, and that simultaneous consideration of learning and patient care, that marriage needs to be enhanced and optimized. So in this report, they have a framework of 6 principles of what represents an optimal interprofessional clinical learning environment. Patient-centeredness, which is more than just centering around the patient, but literally co-creating health with the patient. It talks about the continuum of learning, so pre-professional, graduate, and continuing professional development in that environment, taking in consideration all of the learners, reliable communication, team-based care, shared accountability, so that structures and process are in place to ensure accountability in interprofessionalism, and with measurable outcomes and clear competencies that inform desired behaviors. And then evidence-based practice centered on interprofessional care. So this is a report that just went out there. ACGME is particularly interested in driving the national conversation about interprofessional clinical learning environments. So you can see what I resonated with the presenting situation is totally in alignment with where ACGME and the End Cycle group is headed. So the next concept that I want to talk about is new disruptions and the changing center of the healthcare universe. So one of the things I do is I follow a bunch of websites and I get, newsletters delivered to me. And one of them, this is truly a healthcare consultant called Oliver Wyman Healthcare. But they have, in order to see where the puck is headed, it's interesting to watch what they're talking about. Clearly they're selling a product, but this particular one last summer I thought was really helped in the reframing and rethinking. And so they had a podcast that was, what would Copernicus do? Insights from Health Evolution. And the concept in this podcast was that similar to Ptolemy, so he was born in 100 AD, and the theory that the universe revolved around the earth, which stood the test of time for 15 centuries. And they're saying, similar to the Ptolemy model, that we've designed everything around the provider or the health professional rather than the patient. So they talk about then Copernicus, 16th century, once challenged the commonly accepted notion of the earth as the center of all that is, the center of healthcare's universe is changing. So I'll talk a little bit about that. And so what I want to introduce to you, that was like at the beginning of the scientific revolution, new thinking about science. And frankly, we're into the beginning of new thinking about healthcare today. So another group that we work with is Optum Health and United Healthcare. And 2 years ago, we had one of their vice presidents, Lou Sandy, came in, and he actually gave the plenary keynote at our summit. It was 6 months after the election. A lot of the work at the beginning of the National Center was based in the policies of the Obama administration. So I talked to Lou and I said, I want to know, what are we supposed to be working on? Is this going to stick, that team-based care is in, or what the work that we're doing is going to remain the same? He said to me, Barbara, there's a North Star for the United Health care, and it's based upon team-based care is here to stay. We're investing heavily in it. Value-based payments is what we're working on at United Health System. So bundled payments, whatever we want to call it, pay for performance, and that we are working on consumer-driven healthcare. So not just patient-centeredness, but putting the tools into patients, and in their case, consumer hands, so that they can manage their own healthcare and manage upstream. So Optum Health, which is a subsidiary of United Health, last year surpassed $1 billion in revenue for the first time. And some of it has to do with partnership, acquisition of pharmacy benefit managers. But this is just one third-party payer that's in the game. CVS Health, Aetna, we work with them, and others. So this is the game changer that's occurring. We may not be seeing it today in our local environments, but many environments nationally that we go to are very much moving in this direction. So the first real introduction of policy was during the Obama administration. Secretary Burwell, this is from New England Journal of Medicine, introduced the concept of setting goals for value-based payment, particularly Medicare in CMS. And I think it's already 50% of payments in Medicare are value-based. And so again, another publication that I follow is Becker Hospital Review. It's like a nice snapshot of what's going on. And this particular one talks about federal HHS is launching the new mandatory bundle payment system. So again, not backing off of this concept of value-based payment. I spend a lot of my time in the winter in North Carolina. My husband's retired, and that was part of the deal to keep working. And in January, North Carolina Blue Cross Blue Shield held a major announcement with all of these men that North Carolina Blue Cross Blue Shield will have value-based payments totally in 5 years. So the men who are on this stage is the vice chancellor at Duke. You have the CEO of Wake Med. You have Mark McClellan, who was both FDA and CMS commissioner under the Bush administration. You have Patrick Conway, who headed up the CMMI, which was an innovations investment. And the next person is the interim president of University of North Carolina, Chapel Hill. He was the medical school dean VP, but when Silent Sam came down on campus, and that's been an interesting phenomenon to see, the chancellor and the president left, and he now is the interim president. But again, they are solidarity, talking about value-based payments. And the Department of Family Medicine at UNC is going 100% value-based payments on July 1st. They will not have a risk for another 2 years. So why I want to introduce this concept is what we're seeing, and it's very challenging to have fee-for-service and introducing these models. but we are definitely seeing people thinking very differently about workforce deployment based upon this new thinking about how the work is going to be paid in the future. So I do a lot of work with UNC with a workforce center there called the SHEP Center. And this is a paper that came out in January, which with my colleague Erin Frere, who does a lot of data analysis of what's going on in the workforce, and she's pushing her colleagues to move beyond what she's calling the shortage narrative to what is the real impact going to be once the redesign is really in probably 10 years or so. And so we talk about the marriage of thinking differently about workforce policy and projections, and how do we integrate interprofessional practice and education. So designing around patients rather than populations and not professions. So another strand that came out of the end cycle work with the Accreditation Council on Graduate Medical Education, I was asked to write an invited commentary for academic medicine, and that was published back in January. So the colleagues that I wrote this in with is Simon Kiddo, who's a sociologist, medical sociologist, and Dr. Ron Severo happened to be my academic mentor, and he's another educator. So we're not clinicians, we study the professions, and we were said, what did you experience at end cycle? What was your take on that? So what we wrote about in this article is untying the interprofessional Gordian knot. And what we meant by that is often, so for example, interprofessional education is actually something that started in the 1960s. It's not a shiny new object anymore. But it's not been unusual that all of the other professions are into interprofessional, but medicine is often not at the table. So we write about and congratulate the fact that this movement, this imperative, came out of the Accreditation Council on Graduate Medical Education. So in our opinion, it's the physician leader that sets the table and invites others in as co-equals, and how do we co-create this together? So again, if you'll remember, the presenting situation here is that a physician leader, a department head, is charging and working with her group and to stimulate this conversation in new and different ways. And the role of the leadership is truly at the microsystems or the clinical practice level, the systems level or the health systems level, and then at the macro environment. So this mega conversation about changing policy at the national level is absolutely critical, and frankly at the state level also. In this article, we also talk about the quality improvement efforts and implementation science, and that we often see people trying to implement using those approaches, or what we call technical approaches, but it's this real conversation that I saw in what you have stimulated with the retreat, that really needing to have a conversation about culture, much beyond the very important work with huddles, quality improvement, and the like. So we do quite a bit of research ourselves in the National Center, and some of our so we collect data and have collected data in over 70 sites across the United States. I'll be saying a little bit more about that in 100 programs that are implementing interprofessional practice and education. And through that development, we talk about this nexus team concept, which is bringing education and practice leaders together to create their own team. And what we are learning from our research is that there's 4 critical success factors to be successful in this implementation. So one of the very important ones is, I'm reiterating this, is setting the tone at the top. That it is very important that we move towards team-based care, interprofessional work. There's no question that positioning the effort as very visible and resourcing it is important. And resourcing does not mean money. Money's nice, but time, space, effort is just as important as the financial incentives. Next, we find that people are committed to a culture of health. So moving away from the mental model of health care to really focusing on patients' health. And now we also, in addition to the triple aim, so improving the patient experiences, improving population health, and controlling costs in healthcare system, we now also focus on the quadruple aim. So over the last several years, the importance of health and well-being of clinicians as the secret sauce to all of this work is very much in the mix. So the culture of health, moving away from solely focus on healthcare to health, it now incorporates being concerned about joy, well-being, and health of the clinicians in the system. The other secret sauce, critical success factor, is having a solid, compelling vision. So why are we doing this? And how do we co-create that compelling vision that sets the tone? Where are we headed? Why are we headed? How is this going to happen? So again, another very important critical success factor. And you'll hear me talk about, we have been implementing IPE, literally getting our hands dirty, and many cohorts, or the one that I'm going to talk about is with 16 schools of nursing in universities across the United States. We also are learning that it's important not just to have a compelling vision, but to actually have an elevator speech. You know, how can you talk about the work in 3 minutes or less? That's a very challenging thing to do in something so complex. So this is that cohort that I talked about a minute ago. Our private foundations, Gordon and Betty Moore Foundation, Hartford Foundation, Robert Wood Johnson Foundation, the Josiah Macy Jr. Foundation, came to the center in 2016 and wanted us to do work extending the future of nursing report out of the IOM in 2010. So they have been working on looking at nursing education. One of the 4 pillars was interprofessional teams. And they realized that they hadn't gotten to that as significantly as they wanted to. So they gave us funding to, we had a national RFP that we awarded to 16 nursing schools, just massively support them moving interprofessional education into community settings and developing advanced nurse faculty members to lead teams. So we have a major evaluation going on, and we're working very hard to release a report on this work in April 2019. So these groups got only $50,000 for us, and they actually had to demonstrate a match, and then massive work with them on technical assistance and coaching. And we actually did site visits to all 16 sites last year. So through our external evaluator, there's no questions. We have exemplary sites that we've actually done a deep dive with the evaluator with many interviews, looking at data, looking at what's going on culturally. There's no question that our exemplary sites through this redesign are demonstrating health and patient outcomes. So one of them is Creighton University. They sold their hospital to Catholic Health Initiatives, which moved their hospital 7 miles away. And this is a neighborhood very similar to North Minneapolis. So in the deal, they agreed to build a new ambulatory clinic and a freestanding emergency department. In that redesign, they had never hired a nurse practitioner to lead a team. So they used their funding to do that. And through that nurse-led team, and through the work of collaboration and teaching about the IPEC competencies and the like, they are definitely showing positive impact of the teams. So, and I could go on and on. We have another one in an addiction treatment center in Arizona that is focusing on non-pharmacological interventions with pain. And that involves 5 higher education institutions and health systems and the like. So another emerging theme of this work, and Sasha alluded to the FIPSI course, is having students, having a mandated IPE curriculum is very important. So those sites that are coming in and they're able to just run, that the students and the influence of having faculty members who are educated in teaching teamwork has just set that these early sites are able to demonstrate just very positive outcomes. Yes, there's logistical problems, and they can talk about the strategies that they use. So a laser focus on the patient, you make those logistics go away. How do we get the barriers? Because we're really focused on patients first. Another, and we're finding this as many sites. So I described that the leader of the team is a nurse practitioner in most cases, but the medical school and the medical students are there with the medical residents in many of the cases. And one of the findings of our evaluator in talking to medical residents is what they call the aha moment. And that you have medical residents and we teach them their milestones and how you can be competent as a physician. But when they get into a high-performing team situation in complex need patient populations, it's the aha moment of the importance of the team, and that they do recognize that I don't have the expertise to handle all of our patients' issues. So we're seeing that joy and that aha of how much the team can contribute to, frankly, the medical residents' knowledge about healthcare and outcomes. Very, very, very strong finding is starting with patients and a specific need first. So several of our sites did really intensive assessments. So one of our sites is in Topeka, Kansas, Washburn University, and they are in a low-income public housing. And so they did a lot of work trying to understand the social determinants of health of that population. And again, this particular implementation, the law schools involved, the business schools involved, communication, and they're so successful that the Topeka Housing Authority took one of the apartments and turned it into a clinic because the care was delivered to the patient. Very similar to that addiction treatment in Arizona. And I could go on and on about how exciting this work is. We are also seeing that the PIs, and frankly, in our site visits, we've met with somewhere about 350 people across the 16 sites. Deans come, vice presidents come, but one of the secret sauces is a risk-taking leader. One of the leaders told us, we always start with yes. We don't say no at the beginning. We are also documenting and demonstrating improved teamwork and staff satisfaction throughout these sites. One of the things that people underestimate is the initial time, the time that it takes for team building and time for relationship and reflection. So one of those 6 criteria in that end cycle report about optimizing interprofessional clinical learning environments talks about this very finding physical space and time space and mental space to actually reflect on what we are learning together. Whoops. So there was a report that came out last year, and one of the authors is actually the author of the quadruple aim article on the importance of implementing optimal team-based care to reduce clinician burnout. So this is a big effort by the National Academy of Medicine, is that teams in practice have the opportunity to address the burnout and that's going on in our healthcare workforce today. So out of all of this work that I've described, we're actually very much involved. I'm writing like a fiend right now. We've used tools in this implementation. And so we're understanding what are the important tools to learn or to use when you're doing this type of work. And so this is just, I'm going to introduce you to some of the tools, and we'll be talking later with your team about what might be some possibilities as you get it more and more into this redesign. So one of them is we call the IPE stair step model. And this is something, in 2009, I was asked to give a presentation at HRSA. There's a congressionally mandated advisory committee that's called on community-based, and I think it's now called interprofessional linkages rather than interdisciplinary. And so they wanted to know what's it going to take for community partnerships to really fully implement effective IPE. And so I talked to one of my mentors in the UK who, about what are you seeing, what do you recommend? So this was really the first time this nexus concept came to mind. And the concept of bringing learning and health outcomes together, and that you could actually document this system. So we've tested this, the cohorts have used this model, our evaluators are testing it, and we think that people who are trying to do the work, such as this department, go through developmental stages. And I can tell you my short introduction to your work, looking at your documents, these are the stages. So there's no question you can be working for years with people, but you really don't know them until you really commit to working together. And it's not unusual, and we've used this tool in clinical practices. We've used them, I used it at Ohio State at the presidential level. So this works at multiple levels of the system. And so getting to know each other, spending time, understanding, what are we about is really important. What I saw in the conversations with Dr. Zagaloff is that the commitment to teamwork and to working on developing teams. Next phase is that there is a commitment to making certain patient safety and quality improvement. I saw that in the language of the document from the retreat. Next is by doing teamwork, we're actually doing something different, and we can actually increase access to care. That was your first work group. So all of these are necessary steps and stages in the work. The next ones become a little more challenging as you lay the foundation, and it is workforce optimization. We actually used to talk about team and workforce development, but as I described with the work of value-based payments, as we are able to track with information systems about effectiveness of practice, it's really talking more about how do you optimize the teams and the work to demonstrate the outcomes. And then you can demonstrate the outcomes. And I gave you examples from the work that we're doing in other practices. And then the next piece is that you're driving costs out of systems. And we often talk about the practice side because the pressures are so significant, but higher education actually needs to be talking about the same thing. So what's the efficiency model to drive costs out of the educational system? How can we look at adding value and potentially reducing costs? So we use this model. We give it to people. The group that we're working with, we're actually writing a book. We're going to be having case studies. And we've asked the sites, which of our tools resonate with you? And we want you to write this up. So we'll have one of our sites go, oh, that stair-step model, that was the best mental model for us. We'll do that and we'll show people how we have used it and how it's helped us. The next tool that we use comes out of the Institute of Medicine. So in 2014, they charged a work group, a study group, to look at measuring the impact of interprofessional education on collaborative practice and patient outcomes. So they wanted to know, we have this mandate and charge now. We're talking about interprofessional work. Does this make any difference? What does the literature say? So I actually served on this committee, and some of the best minds in the field, one of them came over from the UK. We looked at, I think it's 29 or 39 systematic reviews. And again, I said we've been trying to do this since the 60s. And what we found was that there really is little evidence, but it has nothing to do that it isn't there. It has everything to do with the quality of the studies and the rigor and the fact that IPE has been up and down. So you'll have it implemented, then somebody will back off of it. So it's never really been implemented longitudinally enough to really isolate the phenomenon. So what we did is we make recommendations about the rigor of the research, what's needed, but we also developed this model. And so this model is called the Interprofessional Continuing Learning Model. And on the left side in blue, we said, yes, we need to be introducing interprofessional work from day one of pre-professional. And now, frankly, undergraduates, pre-BS degrees are starting to introduce the IPEC competencies. But that the bulk of interprofessional learning really should take place at that continuing professional development and continuing education phase in practice. Then on the lower pink left side, we use a model that's called the Kirkpatrick model, and that different learners in the environment actually have different reasons for learning this. So the lowest order is reaction to an experience. So you take a course, you fill out that happiness index about how happy you were with the course. We know from the research that we reviewed, and again, much of it is individual professional evaluations, that we can change attitudes and perceptions about teams. So by doing, training and the like, people feel differently or believe differently about teamwork. And that we can teach knowledge and skills and collaborative practice and performance and practice. So then we focused on what are the outcomes of all of this work. What are we trying to change with patient outcomes, population outcomes, in terms of organizational change and efficiencies? And then what are the interfering and enabling factors of this work? What's the professional culture? What's the institutional culture? Workforce policy, things like scope of practice laws in the state and financing policies. So the tool that we use now is, I actually brought it and I'll give it to you. We've actually had this laminated. So we'll sit it down with teams and they'll start charting out, where are we in all of this? And they'll start talking about those factors and the like and coming back and addressing them. So we have found this to be a very good tool to sort of shape the conversation of the work. This is the reality of today with interprofessional education, is that most implementations is in the classrooms and very little. And we know, again, what's the reaction, perception, and knowledge. We can have an impact in the classroom, but it isn't until you get into practice that we're really going to see the impact of team-based care. So another thing that I've given you is we have practical guides that are about teams. So we teach about how to do teamwork, how to assess it, what's program evaluation look like. We have some case studies. So I've given you our little guides for you to use in your notebook. Another national imperative, which just happened on February 1st, is that the National Center has been working with 24 accreditors, and on February 1st, a guidance about quality interprofessional education for the health professions was released. And what's important about this is that the writing team, the leadership team of this with the National Center was LCME, so medical education, Council on Social Work Education, American Psychological Association accreditor, and pharmacy, the Accreditation Council on Pharmacy Education. They were on the writing team. We developed an outline. It went to a vote for all 24 accreditors. That the outline looked good. We brought it in. We wrote the guidance document. Once we had the draft and they gave a lot of input, it was sent out again to all of the councils. That vote came in the end of November, and again, we've released this. So we've looked at the University of Minnesota. System-wide, there are 16 of these accreditations. And as I've told the provost, you will have a team every year asking about your IPE plan, because we are a large university and each one of these accreditors will be looking for IPE. Will it be perfect right out of the chute? Absolutely not. But the good news is this is very historic. These accreditors have never come to consensus on this nature, this scale of commitment to an area. And as you read it, and I gave this to you also, it really is about the patient and the health system first. So in that document, and I'll briefly talk about this, there's starting to be an understanding that as we have new students coming in, we've always talked about professionalism and professional identity of a profession. At the same time, there's an interprofessional identity, and there's actually a whole bunch of scholars that are starting to work on this. What does that mean? How do you do this? What is a dual identity? So again, over the course of the next decade, this type of research and scholarship will only become more pronounced. So a little bit about what does this teaching model look like? And it's frankly, all are teaching and all learning, including patients are a part of the mix. So we're, at our summit, we actually have a team of, we're calling it super patients. Some of them actually are given faculty appointments in their universities, University of Montreal, University of Southern California, specifically because they are patients. So in Montreal, if you're going to teach about diabetes, you're going to be taught by a diabetic who is specially skilled in teaching. So there's also something called workplace learning, so valuing that informal learning of every day. How do we capitalize on that? How do we reflect on that? And so that just the natural cadence of practice is where you learn. Probably one of the best examples, so I go into clinical environments and talk to a lot of people. Rochester, New York, the Highland Clinic was probably the best example of medical students teaching the faculty. And it had to do with their metrics on quality improvement around high blood pressure, hypertension. And it was a medical student that noticed that when the MAs or the nurse was putting patients in a room and finding high blood pressure, that the clinician would race in and not look at what was, what that reading was. So it was the simple QI of putting the blood pressure cuff on the computer keyboard that was indicator to the clinician that, you better check the blood pressure again. So again, when you go into these all teach, all learn environments, you see something very different about, frankly, what we know now is psychological safety coming out of the Google study of about 2 years ago. So just a little, I'm mindful of the time, and I want to make certain that I take your questions, is why is this so difficult? Why? It's really hard work. And one of it has to do is that we're actually living in a system that's 100 years old, and it's really becoming outmoded every day. So the gentleman on the left is Abraham Flexner, who wrote the famous report in 1910, and very necessary report because medical schools and medicine education was just all over the place. And so he's the one that introduced the concept of the scientific curriculum at the beginning. It's now why the boards are based upon science. The first school to really implement it was Johns Hopkins. And there's even an organization now that's called Beyond Flexner, which is like, this system's broke, we need to fix it. But I like to look at the world in terms of history. And so I tell people a really good book is about the assassination of President Garfield in 1881 by a madman. And so it's called Madness, Medicine, and Murder of a President. So what happened is President Garfield was shot by Charles Guiteau, and there's varying post-diagnoses from was he a schizophrenic or what. And where the bullet lodged, if they had just left it in place, he would have lived. Garfield would have lived. But they called in the physician who attended to Abraham Lincoln in 1865, and he kept sticking his hand in and trying to pull out the bullet. So he was introducing infection and bacteria at a time when the reality and the understanding of hand washing and the like. And there was a female physician who was trying to tell everyone what was going on. Science is now telling us X, Y, and Z. This is not right. But no one listened to her, and he died. It's a wonderful story if you really want to understand where we are at the beginning of our new scientific revolution. The other part of the story is the first team documented in the United States was actually at Mass General Hospital. And it was a physician, Richard Cabot, and a social worker, Ida Cannon. And I found this article every year. There used to be a publication that came out talking about the scientific innovations of the day. In this particular 1941 book was actually Orville and Wilbur Wright. So what it talked about was the innovation of teamwork and how important the social worker was in poverty, tuberculosis care, charity care, that it was a social worker working with what we now would call social determinants of health that actually made the physician's advice. It talks about the benefit of the physician advice. So again, that team. However, at the time when Dr. Flexner, Mr. Flexner, there was a lot going on about whether a profession was a profession or not. And so he wrote an article, was asked to write an article in 1920 about whether social work is a profession. So the tone was set during that decade for what we are living with now. A hierarchy, if you weren't science-based, so this article went through its 20 torturous pages and literally talks about the difference of amateur and professionals. And he concluded that because social work at the time was not a scientifically based profession, it was not a profession. So the 20th century, we've had specializations, accreditation, all this stuff that's been happening. And so this concept and the ideas now that we're talking about is really questioning how our professions today are actually implemented. This is a book, and I've given you the reference on the future of the professions, on the effect of technology, cost and quality. Again, how the professions are changing in general. So, and if I think about what it might look like to have a workplace learning organization, every profession has a body of research about their benefits in the delivery system. This just happens to be social work and looking at what is the impact of social work on social determinants of health. You know, we see many environments where students are learning about this in practice. So this having the students for longitudinally here and the opportunity for students to actually introduce this conversation. And again, we see things like students are doing modules. We see all staff in clinics taking the students' modules. So again, what might potentially make sense in this all teach, all learn environment? So I'm going to quickly go through our research agenda in the National Center, and I'm glad that Connie Delaney left because I'm the least qualified of our team to talk about this. So Connie Delaney, who is our Dean of Nursing here at Minnesota, is a world's renowned expert in health informatics. She writes about big data in nursing and the like. She heads up our interdisciplinary research team in the National Center, which is an informatics platform. And we talk about, rather than research, knowledge generation, and we actually talk about IPE science. So over the course of our experience in collecting data, we have developed an IPE core data set that we'll be introducing nationally. This is our team. So people like Jim Bacala has been our team. We have 2 physicians, nurses, informaticists. And what we've been working on with this core data set is standard measures that are applicable and comparable across environments. So the standardization is to advance our collective understanding of what works and doesn't work in IPE. So trying to get past this individual program evaluation to standardization. So this core data set is standardized, it's shareable, comparable data, and when possible, using existing data that is readily collected in the delivery system. And then where we're headed towards this is empowering state-of-the-art analytics. So we have built our platform based upon the university platform that with CTSI and the Institute of Health Informatics. We've taken that IOM model and we've really expanded it based upon data we're already collecting, based upon experience. We have identified what we believe are the core variables underneath this work. And what you see on the right side is that essential core data set. And so we have a program proposal process that people who come in fill out. And it's not just about research, it's really about reflecting rigorously on IPE program development. And that's where the left-hand side of the essential data set is. That has to do with the program proposal. And then we collect data on something on standardized instruments. One's called the ICAS. Another one is called ACE-15, which is Assessing Collaborative Environments and the like. So as I was preparing this, as I was reading your retreats and the emphasis on teams, what you'll see is, again, this isn't just about data and research. I'm not going to spend time on that, but it's about, we know how to bring data in a secured HIPAA and FERPA, which is the student compliant infrastructure and data sharing. And again, it's housed here at the university. I've talked about the core data set, but the team at IHI has built out informatics dashboards. So you put your data in and you can get your own data out in the automatic. They have it already programmed in, and then you yourself can do program management. And as we have more and more sites putting in data, that comparable, shareable part will start to come in. So as I re-looked at what you're working on, one of the instruments is this ACE-15. You can invite 100 people to take that instrument, and it is 15 items on teamness. And it's anonymous, and then you could get your scores. Now, eventually we want that comparison to other environments, even within a single system. But again, it is like, this is where we are with, are we a team? Let's talk about it. What are we seeing? So we have built this again for research, to support clinical environments, but also to help with the development of teams. this is just the informatics peeps are doing this. So again, you come in, you do a program proposal, you automatically get survey instruments, you can put in your patient health outcomes and the like, and then you get standardized reports on your own work. And this is what a proposal looks like. We coach on study design, who are the learners, what is the environment, really focusing on health and patient outcomes. And we talk about sustainability. And then how are you going to disseminate your results? People who are faculty, they need research, they need it for promotion and tenure. So this is my very last slide. As I reflect on the department, here are some points for you to ponder. What is the compelling vision for practice redesign around teams? So what is it? How are we going to articulate it and communicate it? How are patients and families involved in the co-creation? Is that happening? What are opportunities for that co-creation? And then what patient and population and organizational systems outcomes are we going to articulate and are we trying to achieve? And then my last point for you to ponder is, how are we going to celebrate what we've already accomplished? Because I will tell you, it is a lot. It may not feel like it at this particular point, but I will tell you some of the things that I'm seeing, you really have things to already celebrate. And so how are you going to do it? So this is our summit. I hope you come. We would love for you to be involved and to submit the call for abstracts are out. And again, this is going to be co-hosted by the Accreditation Council on Graduate Medical Education and their collaborative, the National Collaborative on Improving Clinical Learning Environments. So I'm going to stop there and be happy to take any questions or reflections or did you really mean this? So thank you.
Thank you very much for a really thought-provoking talk. I've been pondering your last slide since the beginning of your talk, essentially these particular questions. But maybe I could solicit
so these are what you've been pondering yourself.
And maybe I can actually solicit a little bit of help, and that kind of help us move in that direction. You mentioned value-based reimbursement. And so the two related questions are mental illness, mental health is a chronic disease. And so in your experience, where should the outcome lie? I know it's a very, very broad question, but because that also would then tie into the value-based reimbursement. Right. Which is also, they're interconnected. And the second related question is, what has been the success stories to transition from fee-for-service in a system that is really 100-year-old based on that, and the vision that this kind of value-based system will be implemented 4 or 5 years down the road, and the challenges of actually meeting both, meaning forward-thinking while really having to deal with the reality.
And I have a slide, I didn't put it in there, which people often refer to the boat. I don't know if you've seen the boat and the boat, whatever it's called, where you have 1 foot in the boat and 1 foot on the shore, and you're going like that. And that's what it feels like now, because I go into some environments where it isn't happening at all. It's still firmly fee for service, and frankly, building whole hospitals based on that model. and I go into other environments where they're moving far ahead already. But I have to say that I presented United Health because just last week they got the license to do care in Minnesota, that it's really going to be those third-party payers that are going to drive the conversation. And what we're seeing is patient-payer partnerships. So, CVS is partnered with Aetna, and they want to be your front door to primary care. Now, we could laugh about that all we want, but when you get the big players in, we've got to pay attention. So one of the things I want to tell you is I do not have a crystal ball. I know that you would like for me to say this, but I will say that having that in the back of the mind and what does this really mean is really a conversation. And that probably might be that one work group about financials. But again, it's not happening now, but it could be happening. What does that mean? And again, we do support, and we is back there, he's the guy who's doing it. HRSA and SAMHSA, frankly, have funded a lot of behavioral mental health initiatives. There is a lot of innovation going on. But it's hard to isolate what it is, because it's, again, this 10,000 flowers are blooming. And so I tell people to look at those initiatives, and is there something that is applicable to your own environment? And then as you think through this redesign, and again, you're not quite there yet. You're really laying the groundwork for this conversation. What might make sense about that optimization of teams? So we have been in C-suites in very large health systems that are academic health systems. And again, what's ironic, I haven't really talked here at Minnesota, but we are actually seeing that informatics, that the health information is really driving some decision making. So if a place like University of Pittsburgh Medical Center, which has been highly successful in the fee-for-service model, now has mega competition in Pittsburgh. So they're taking a look and they're running models on fee-for-service versus teams, and do we need to be training this many X, Y, and Zs? Those conversations are going on. Another example, and a lot of this is proprietary information. They don't go running around telling people what their strategies are. I gave a talk here about a year ago in the School of Social Work. And they had a panel of clinicians, and one was a director of social work, respond to my talk. And she actually was from Essentia at St. Mary's. And she talked about that at the C-suite level, they are crunching the numbers on effectiveness of teams. And the number one team at St. Mary's at the time was the oncology team. And so when they got underneath the model, it was the hospitalist oncologist, it was a nurse, pharmacist, and a social worker, and the effectiveness of that team for outcomes. So the social worker looking at social determinants of health, it was so striking that they're questioning the hospitalist model because going from floor to floor, and that it's about the relationship building of the team. And the other thing is that director of social work was told to hire 6 more social workers, that they were so convinced of the effectiveness of that health professional that it was important. But what I'm telling you is this is a data-driven. So this isn't, as you get into this conversation about the data and the like, that's going to also drive your conversations about the composition of the team. So I don't know if I answered your question, but, there is no crystal ball. There is none.
Doctor, the comments about United Health make me think of something I just read in the New York Times this morning.
Another good publication to follow, by the way.
The judge found that the United Health was systematically denying care for the chronic, for the outpatient, and for the institutionalized. They were providing only payment for acute crisis, and they were not going to pay. So United Health is coming to Minnesota. I'm worried about who's watching them. And the second one is, for Dr. Vinograda, I'm glad you're here, because in previous decades, There was, and in fact, the previous dean was all about first and last author, how many publications, how many citations, the wall of honor, and it was the best and the brightest. I see that as the worst cog against teamwork that I can think of. That if you reward teams, you'll get teamwork. If you reward the best and the brightest, what you'll get is individuals who publish a great deal but don't share. And I think that idea about the university only rewards publications, in 1998, the regents came out and said, we're across the university not rewarding teaching. And they said you have to have equal teaching and publications to be advanced, and that's been honored in the absence. It's not been rewarded. It hasn't resulted in advancement, and I think that's something that the regents and the deans of the medical school have to be held accountable to. If we happen to have a great leader who's able to bring together teams and reward that, we're fortunate. I think pediatrics does that well. And we were just at pediatric rounds this morning on cancer treatment. That's across the country and across the world. That's how we're brought neuroblastoma from 9% cure rates just 15 years ago to 52% cure rates by interprofessional cooperation. I just think we're stuck with...
Do you want to answer, or do you want me to?
I'm going to expand on the comment in some way, which is, you were saying how in our own backyard things are very complicated and perhaps not modeling what we know we should be modeling. And I'm just struck by we have this new joint clinical enterprise between Fairview and the university, UMP. And there's, this big launch, new relationship, vision for the future, meeting the healthcare needs of the future. And I haven't heard interprofessional practice or education, not even a peep about it.
Well, you're going to tell them, aren't you?
Well, I am, but that's sort of fascinating.
I find it fascinating too, but I won't say that publicly. The one thing I want to say to you, I was the vice president of education for 15 years here. I'm very focused on the national environment now. I have read over 600 dossiers in 9 years. So I used to be charged with all the health sciences promotion and tenure. So I know the lifeblood of this university. And there's nothing in the 712 statements that precludes interprofessional interdisciplinary work. But it's helping to support our faculty understand, yes, you have to demonstrate independent thought, but you also now, and frankly, the NIH is, and their team science initiative, which, oh, by the way, is the exact knowledge basis, the interprofessional education, is actually putting an emphasis on it. The irony is there's only one university that I know of that has tapped into the expertise of people who know about interprofessional practice and education and teams, and that's actually University of Washington. If you take a look at the literature, same authors, exact same. Matter of fact, one of them helped us develop those 5 practical guides. So I would say that the emphasis is coming more and more on team science and teams and practice. So, and I would be more than happy to have the conversation. It's a very important one. Anybody else? I just want to congratulate you. I think you're doing a terrific job. So thank you for inviting me to present.
Yeah, thank you so much for being here. And if we can give Dr. Brandt a thank you.
You have been disconnected from the meeting.